Okay. I don't have any notes. I am getting called to do a spinal epidural on a first-time mother who's 30 years old. I did my chart review and my lab review already, and I will also go and speak to her. I'm going to identify her name and date of birth, and then I'll review the chart with her as well. So platelets were over 200,000, or were over 100,000. They were 200,000. There were no issues with her CBC panel from this morning either. And then for her chart review, she doesn't have any allergies. She confirms that she doesn't take any medications, including herbal supplements. She confirms that. And then no known history, medical-wise or surgical-wise. And then just system assessment-wise, she doesn't have any neurologic issues, no history of strokes, migraines. She doesn't have a headache right now. No neuropathy or muscle weakness, neurologic weakness. And then cardiac-wise, she doesn't have any history of heart failure. She doesn't have any history of fixed volume cardiac issues like aortic stenosis that would cause issues with hypotension. And then no respiratory issues, no difficulty breathing. She doesn't have any coagulopathies, and so we're clear to do the procedure. I'm just going to explain it to her. I'm going to explain the indications, risks, and benefits to make sure she understands in order to consent her. So indications for this would be pain control during labor. If we were to, pain during labor. Risks would be neurologic, so like total spinal, post-dural spinal headache, risk of bleeding, risk of infection, risk of nerve damage, pain with injection, as well as risks in particular with the medication I'm giving, like tachycardia, seizure, cardiac arrest, and nausea and vomiting. So she doesn't have any questions. She is okay with the risks, and she still wants to proceed, so I'm going to consent her. And then I'm going to make sure that I have my kit all sterilely laid out, and I am going to have my medications pulled up. So I'm going to be using a local first subcutaneously, and that's going to be a 1% lidocaine 3 mils in a 25 gauge needle. And then I'm also going to be doing a test dose that is going to be a 1.5% lidocaine 3 mils and 1 in 200,000 epi. So that's going to be 45 grams of lido, and it's going to be 15 mgs of epi. And then my epidural dosing is going to be a 0.25% bupivacaine. It's going to be with fentanyl. It's going to be 8 mils of the 0.25%, and then it's going to be 100 mgs of the fentanyl. And so it's going to be a total of 10 mils. And so I have that all drawn up already, as well as sterile saline in my glass pressure loss syringe. Actually, I'm going to do that after I'm all sterile. But in the meantime, we're going to make sure that she is all positioned. The nurse is going to help me with that. She's going to be in a mad cat position just to open up the spine to make sure that I can access the intervertebral spaces more easily. And she's got her knees up to help round her back out. And I'm going to have marked her for insertion site. I'm going to be looking for her tooth line, which is going to be L4. I'm going to find that by looking for the iliac crests and going midline, and then I'm going to be inserting L2 to L3. So I'll just be counting up the spaces, and I'll be marking that And so yeah, I'll be using a midline approach. So I'll be inserting my needle in the intervertebral space at 90 degrees. That's plan A. Plan B would be paramedian, which would be 1 centimeter lateral, 1 centimeter caudal at a 45-degree angle. So with that all said, I am sterile. Then I would drop all my meds that I had calculated earlier. And I am going to clean her back really well, making sure I go up a little bit higher, down a little higher, and over to the sides. And then I'm going to sterilely drape her. And then I'm going to take my local that I had mentioned earlier. I'm going to give the subcutaneous injection, and I'm going to inject as I pull the syringe out. And then I'm going to take my 2E needle, and I'm going to insert at the 90-degree angle with a Bromage grip so that I don't puncture further than I want to. And I'm going to get close to where my ligamentum flavum would be. So I'm going through the skin, the sub-Q tissue. I'm going through the supraspinatus, infraspinatus, and then ligamentum flavum, which is where I'll feel the loss of resistance in the first pop to get into the epidural space. And so I have my syringe that has my sterile saline on it, and I feel my loss of resistance with my needle and with my syringe. And so I'm going to take that off. I'm going to note what marking I'm at. So each marking is a centimeter, and I'm at 5 centimeters. And then I'm going to take my catheter, and I want to thread this 5 centimeters into the epidural space. So I'm going to be adding the 5 centimeters that's already in the skin to the epidural space, plus another 5 to get to 10 on my catheter. So continuing to use the Bromage grip, holding my needle, I'm going to thread that. And then once I'm at 10 centimeters, I'm going to remove my needle, being careful to leave my catheter in the same position. So then I'm going to coil up my catheter really nice so it doesn't get pulled when I put the tegaderm on. And then also I'm going, actually before I do that, I'm going to finish this. I'm going to put on my little alligator clip, and I'm going to put on my filter needle so there's no glass shards that get into the patient. And then I'm going to give my test dose. So with my test dose, I'm going to be looking for any signs of an intrathecal or intravascular injection. Intrathecal injection would be a sudden profound block, and an intravascular injection would be any hypertension, tachycardia, metallic taste. I would be, seen on the monitor as well. And so since that didn't happen, I can now give the bupivacaine that I had mentioned earlier that I drip. And then I'm going to coil it up. I'm going to tegaderm it really well. And I will be checking her vital signs every 5 minutes for 15 minutes. And I'll also be charting, I will have been checking with the drugs that I gave, the level of autonomic, sensory, and if I can, motor sensation as well. So with an alcohol swab and then with pinprick and sensation. So I'm going to chart the level of block as well as the 5 centimeters that I have threaded into the epidural space and the 5 centimeters I have epidural to skin. So that was my epidural. So for the next one, we're going to do spinal. For the sake of this video, I'm just going to say that I've already consented her on it. I've already prepped everything. I've cleaned the site, and then I am sterile. I've drawn up the medication that I'm going to give. I'm going to be giving a 0.5% bupivacaine. I'm going to be giving 10 mils of it And then I also have already done a local injection, the sub-Q injection with lidocaine. So now I am going to take my spinal needle. It is a 22 gauge pencil point. The epidural was a 2E, if I didn't mention that already, and 17 gauge. And then I'm going to be inserting at that L2 to L3. I want to be below the conus medullaris for the spinal so that I don't risk as much injury in the spinal cord. So I'm going to be inserting until I feel loss of resistance, and then I'm going to take out my chlorine stylet. This specific stylet that I used for the epidural doesn't have the chlorine stylet on it, but I would also have done that for that, where once you get past, once you're getting close to the ligamentum flavum, you would take out your chlorine stylet. All right. So then I'm going to advance my spinal needle, and I'm going to take my syringe to check for CSF. So the layers that I went through for this were same as before up to the epidural space, and then I'm going through the dura mater, I'm going through the subdural potential space, I'm going through the arachnoid mater, and then the subarachnoid space, which is where the CSF is, which is where my spinal needle should be. So I can see that I have CSF, and I'm going to rotate 90 degrees and rotate 90 degrees checking, and I can give my medication that I said I was going to give. And so I administer the block, I'm going to remove the needle, and then I'm going to be once again assessing where the autonomic, where the sensory, and where the motor block is at, as well as checking vitals for this every 2 to 5 minutes.
Nice.